Good morning everybody and welcome to another Insight APSAD webinar. My name's Jim Hunt, I'm one of the nurses here with Insight. To start with, I'd like to acknowledge the traditional owners and custodians of the land on which we're meeting today, and I'd like to pay my respects to elders past, present and emerging, and I'd like to extend that welcome and respect to any Aboriginal or Torres Strait Islanders that might be joining us in the room today, or indeed on webinar land. So welcome and thank you. Today it gives me good pleasure to introduce somebody that I had the joy of working with a few years ago, Dr. Angelo De Gioannis, and he's going to give us a presentation on how ketamine may well be one of the answers in managing depression and anxiety, which is quite an important thing when you realise that depression is probably the leading admission for hospitals in relation to mental illness. So Dr. Angelo, if you'd like to come up and give us your presentation, please.
Thank you. Good morning, everybody. And I have shrunk the presentation as much as I could so that we have more extra time for questions at the end, because obviously I know you'll come to this presentation with different ideas and interests. So I hope I can answer all the queries. So what we're going to talk about is oral ketamine and as augmentation, which is to differentiate from what I guess most people know about ketamine, where it's used as an infusion or as an injection. And that's why we're going to talk about how giving oral ketamine in small doses or sub-dissociative or sub-anesthetic doses can help in the treatment of treatment-resistant depression and anxiety. You may be familiar with the idea that the current treatments for anxiety and depression only work in around 1/3 of the patients. So it means that 2/3 of the patients treated either don't respond or only respond marginally. So there's a big gap in our ability to help people with these illnesses. And that's why we tend to be so desperate about trying anything that can help to reduce the burden on patients and families and society. So we're going to talk about the fact that ketamine is known as many different things. So there's lots of mechanisms of action that have been described around ketamine. This is the translation of the figure you saw before, but the only reason why I prescribe ketamine, and I've been prescribing it now since 2012, is for this. And this is in fact what I show patients, what I show colleagues, because in essence this is the reason why we should at least consider ketamine. So the first picture is a brain cell without any stress, anxiety and depression. The second one is what the same brain cell looks like after 3 weeks of stress. Can you see the difference? Yeah. Then the third one is what the same brain cell, obviously they did it on mice, not humans, the same brain cell looks like the day after ketamine, after the 3 weeks of stress. And this is a very good representation of what we see in clinical practice. So when we give ketamine, assuming the dose has been sufficient, or I guess we see the same when we do an infusion or an injection. In my case, giving it orally is a bit more gradual process. We see a clinical representation of these pictures. So people are calm, can think clearly, can focus on tasks, and can actually put into place strategies and actions to manage whatever is going on. And this is why for the last 7 years I've gone through a lot of trouble with obviously mainly other colleagues, because obviously there's resistance in our field to adopting things like ketamine as a treatment. I have to say that authorities have been actually pretty good to me, so I would like to thank sort of by Allah. That's why I'm always happy to come here, because of all the people I've had to deal with over the last 7-8 years, fortunately, you have been the nicest. So that's why I'm happy to pay back any way I can. So what we observe in, and this is a general statement about ketamine, so it doesn't really matter whether you talk about infusions or injections or intranasal or oral. That's what ketamine does. It's remission in over 50% within 2 or 3 months, and the response rate is around 2/3 of the patients. Of those who don't respond, so it's 2/3 of the 2/3 who don't respond. And so we haven't actually got to the point of giving ketamine to the general population, so we don't know, in fact, how quickly and how well people would respond if they had ketamine first up. And hopefully we'll get to that in the next few years. And obviously, what's also important is the fact that the chronicity and the presence of personality disorders interferes with response. By and large, what we have been observing over the last few years is that there's only 10 to 20% who don't benefit from ketamine. And we haven't really looked into why and how. I guess my gut feeling is usually related to personality, extent of the personality disorder, and secondary gain and motivation to change, which interfere with response. But I guess fortunately it's so limited that we haven't got to that point. When we look at anxiety disorders, in fact, the response rate is very similar. It's just that in literature there's a lot of work done on treatment-resistant depression, but in our clinic, because we allow the whole range of neurosis to be referred, we find that in fact, PTSD responds to ketamine even better than depression. OCD, I've always had a bit more caution about the response, but it always helps with the depression component. And what's important is that we reinforce from even before our patients start the treatment is that ketamine is not the treatment. So ketamine is what we give so that patients can receive the treatment, which is usually psychotherapy. So at the end of the day, what makes people well enough to be discharged from ketamine is psychological change. It's about accepting that if the illness is severe and chronic, very difficult to achieve meaningful psychological change. And that's the important component. And so in terms of giving you data about what we've done so far, there's a few bits and pieces that we have collected. Most of all, we have focused, especially because of the population referred to us initially, which was a population who had been receiving ECT with no response, spending weeks and weeks in hospital with no remission of symptoms. So that's why we looked at how much people were suicidal, how many days in hospital they spent, how many presentations to emergency they had, and that's why we went from for the 50 patients we looked at as part of our trial. The days in hospital went from 1,200 to 250, and sort of within 6 months of starting the treatment. And then for the patients who had been receiving before ketamine maintenance ECT, so patients who couldn't stay well without ECT, 5 out of 6, we were able to stop ECT and just continue with ketamine. And in fact, this morning I saw one in particular who had been having maintenance ECT for 5 years, and he's now 3 years since his last ECT, and he has 150 milligrams of ketamine a week. That's all it takes. And so imagine avoiding going to hospital twice a week for shock treatment. And obviously, because of the picture that I showed you before, not only the brain gets healthier, and obviously we're talking about neuroplasticity, that's the topic. Neuroplasticity helps with psychological change. Obviously, whatever medication people are on, because the brain cells are healthier and plumpier, whatever medication people need, they'll need less of it. So this is what the data looks like in terms of the admission rates before and after starting ketamine. This is the average number of days in hospital before and after. And I guess I'll describe now how we do it. So what we do is very simple, and that's why if you're familiar with the way you do methadone and Suboxone, so we start at a low dose. We usually start at the clinic. It's a lozenge, it's like a lolly, and patients hold it in their mouth the first time just to check for allergic reactions, which we haven't seen. We don't know what allergy to ketamine looks like, and but we still do it to get an idea of whether there's any sort of intolerance. And we start usually at 0.5 milligrams per kilo because it's the dose we normally use for infusions. So considering that bioavailability of ketamine is about 10-20% compared to IV, we're definitely at 20% the dose of an infusion. And that's where we start. And then we increase by 25 milligrams every second day. So the treatment patients take every second day, they take at home, and if there's a responsible adult at home, they're allowed to increase the dose gradually on their own. Otherwise, we do it at the clinic under supervision. And after each dose, we observe for 30 minutes. After 30 minutes, if there is a psychotropic effect from ketamine, we'll see it. And the idea is to check for, it can be sedation, it can be spacing out. Some people get nausea, some people get nystagmus, the eyes start to flicker. And the idea is that increasing it gradually, we get to the point where there's some vague side effect for usually 10-15 minutes, and that's why we stop increasing and reduce back to the previous dose. So the idea is to have as much of the antidepressant effect without any psychotropic effect. What we use is the glass of wine concept. So after ketamine, the most we allow people to have is like a Valium experience or a glass of wine experience for 10-15 minutes. And in fact, people are not supposed to keep having it. So that's sort of a bit of a benchmark for us to know that ketamine is getting to the brain in sufficient amounts, and that's where patients keep the dose. What we have found is that the average dose is between 1 and 2 milligrams per kilo, and imagine these days we have about 400 patients currently under on ketamine treatment, and the dose goes from 10 milligram lozenge to 800 milligram. So very wide therapeutic range, and the idea is that obviously there's all different variables, but at the end of the day, we give whatever the brain needs to have an effect without the anesthetic or psychedelic effects. The frequency, depending on patients' lifestyle and preferences, goes from weekly to daily. Generally, it's every second day, and the reason for that is dual. One is to reduce the frequency as much as we can to protect the bladder, which is the main risk with ketamine, bladder damage, and the other one is to deter patients from the idea of ketamine as the treatment. So we need to reinforce the idea that ketamine is an aid to the treatment. The real treatment is the psychological treatment and whatever else they're doing to get better. Ketamine allows you to do it more easily. And patients who take it daily is a limited number of patients, and it's generally because of the extent of the chronic pain. So some patients describe some benefit for pain, and that's why with extra monitoring we allow daily doses. And the cost of the lozenges is on average $20-30 a month. It's a compounded sort of a formulation. It's available anywhere because compounding pharmacies are very familiar with ketamine lozenges for chronic pain patients, so it's very widely available. And consultations are, just the usual. In fact, we are lower than average in terms of gaps for consultations compared to private psychiatrists and private doctors. So no allergic reactions. The blood pressure concerns usually present with ketamine have not been an issue for us because of the gradual increases and the fact that we screen patients for blood pressure issues before the treatment, and that's why we've never had to treat actively patients for side effects. So the maximum we have had to do over the years is to give a Maxolon injection if nausea was severe enough, but otherwise we haven't had to do anything because by the time we give the medication, the side effects usually subside by themselves anyway, because ketamine is so short-acting that side effects are very transient. Obviously, the side effects are dose-dependent, and the most frequent reason for dissociation or sedation from ketamine is because people have forgotten to have food. So it doesn't matter whether people eat or not, but if we titrate the patient on empty stomach, they have to stick to the empty stomach. If we titrate on a full stomach, so they have to keep the food intake consistent, because otherwise the absorption changes. So that's the only thing patients have to be careful with. And what what I was going to reinforce here is the idea that over the years we have confirmed that there's no evidence of tolerance building. If we have to increase the dose, it's usually because we are reducing other medication. And the rule of thumb is that as we achieve a response and remission of depression and anxiety, the dose goes down to about half. And in fact, what we normally see is that as patients improve clinically, we have to withdraw ketamine as a result. So patients can't take even small amounts. So the last example is a patient who on maintenance was on 200 milligrams of ketamine every second day. Now that he's in remission, we tried, for his anxiety, we tried 25 milligrams, he couldn't take it. Was too sedating and was, I guess, he didn't like the feeling. And as I said before, psychological intervention is paramount. We exclude patients with unstable hypertension, so the patients who have hypertension that's not really under control and erratic. Obviously, intracranial pressure is something we keep an eye on. We've had a number of patients with different conditions over the years, and assuming we liaise with the neurologists and there was enough medical attention, we've been able to give ketamine without any problems. And obviously, yeah, we don't give ketamine if there's an existing substance use disorder, and for various reasons. And that's why the workup includes very straightforward blood tests. We do an ECG, urine test, and then we check regularly during the treatment. Definitely, we haven't seen any weight gain, sexual dysfunction, and even these concerns that have been raised about neurotoxicity of ketamine. So we know that ketamine abusers have brain damage from repeated and sort of a high ketamine use. We have been able to treat professionals and doctors, lawyers, architects, and they don't complain even after years of ketamine taking that their cognitive functions are impaired as a result of the treatment beyond the impact from the anxiety and depression. So far we have treated over 1,000 patients. We're not counting anymore. And personally, I am now involved in, so I see obviously some patients, but I'm mostly involved in supervising and coordinating clinics. And the clinics are here in Brisbane. There's 2 of them, and they're both medical centers where there's GPs. And so we do the treatment in conjunction with GP practice. And there's about 12 psychiatrists and GPs, and Nicole is the sort of a odd one out. And but in a way, there's all different doctors involved in the program, and we see about 150 patients a week. And again, no medical complications that we have observed. And so the ketamine are available very easily and cheaply from compounding pharmacies. Because it's a lozenge, it can be injected. It doesn't, so it's not that work. And people have tried, it's hard work. And the way we run the clinic, in terms of, so for people to get an idea, it's like a Suboxone clinic where initially you get a few days supply, and then depending on how trustworthy you are and how stable the dose is, you get longer and longer, and to the point where people come in, we have the consultation, we obviously we make sure things are all in check, and that's why patients pick up a script. Well, in fact, they don't take the script. We send the script to the compounding pharmacy, and they pick up their supply, and that's how it works. And the College of Psychiatrists expects 2 doctors involved in ketamine treatment. So whenever we do ketamine treatment, there's at least 2 of us who have, in fact, the ideal is where patients have their own psychiatrist, and then we see the patient for the ketamine treatment, but the treatment is monitored and supervised by an independent doctor who is not involved with the program to confirm that the treatment is appropriate and is not doing any damage. And the main problems we've had with ketamine, which are not really that big problems, but is the fact that we're constantly readjusting the dosage because people change in severity, which is good, but also it can be that we have to manage a relapse. So in a way, we have to be flexible in adjusting the dose and the frequency accordingly. And then, what we obviously have to do a lot of, that normally we don't do, is to make sure ketamine is given to the right people, or that ketamine is not accessible by significant others. And so that's why we have to sort of be watchful from that point of view. And then, the idea is that the problem is even amongst ourselves, we have to make sure ketamine doesn't end up in the wrong hands, so it's about keeping an eye on the doctors involved and making sure we're all sensible and doing things by the book and behaving. And do you know? Are you aware of these controversial? No. Good. You don't need to know. No, like I said, so it's a well-meaning professor in Melbourne who got so excited about ketamine, as you do, because it makes you excited when you see patients get better. Obviously, I know the feeling. And unfortunately, it blew it because he started making it available too easily. And then other people jumped on board and made it into a business, and that's why they started making money out of ketamine, and gradually got less and less ethical in their practice, and that's good. So I have concluded the official part of the presentation. How long was it? Yeah, that's right.
Yeah, we've got about 20 minutes left, so we can
so that's why, the idea is...
I firstly thank you.
Yeah.
We'll thank you properly in a minute, but I'm sure there'll be some questions, and I certainly have a few. I was lucky enough to come to your clinic and watch the process. But for people that aren't aware and aren't familiar, I'm going to ask some questions that I
that's right.
So who provides the psychotherapy during your session time?
Well, I guess sort of the consultation is mainly about the ketamine monitoring and the prescribing. Then the psychotherapy depends on the patient and the clinician. Obviously, some of the doctors involved don't give personally psychotherapy, but we have to make sure that patients get it somewhere. And obviously, we're flexible. It doesn't have to be that specific psychotherapy. So it has to be reinforced, the idea that ketamine only works long term, and in fact, we only get a chance at discharging patients from ketamine if and when there is psychological change. So the assumption is that obviously patients are so desperate, unfortunately, that they'll take anything and will accept having to take it for the rest of their lives. Personally, I can speak for myself, but personally, I don't want patients to become ketamine patients for life. And also experience shows us that if we have seen more than 1,000 patients over the years, but we're only seeing 300, patients can be discharged. And that's why it's about reinforcing the idea that obviously it's more challenging to change and to go through psychological treatment and do other things.
And unlike the MDMA, for example, psychotherapy, assisted therapy, the psychotherapy doesn't have to be done
during. No, because patients take ketamine in the evening usually. They take the lozenge before they go to bed. So there's no psychotherapy under the influence of ketamine. Obviously, some clinicians use ketamine injections to do psychotherapy during the ketamine affected state. But obviously that's a specific practice. In our case, is not together.
Thank you. There's probably other questions in the room, and I have some more. So yes, I'm going to run around and take some others.
Thank you for that presentation. I noticed that you said there was a good response from PTSD. What about like complex trauma cases? Does it lose its efficacy there, or do you have?
Even better. Complex trauma, yeah, that's a PTSD, that's why I gave it. So most of the patients we have seen, in fact, it is complex PTSD and borderline, because in fact, my previous presentation here at Biala was for borderline. So most of the patients we have treated, because I was getting, and I've been getting for years, referrals for borderline patients, most of the patients with PTSD in the study had complex PTSD from sort of developmental abuse and neglect. And that's, we have seen there's another group of PTSD from, I guess, conflict, and so veterans, and also there the response, in fact the response rate was pretty good, even better than complex PTSD, but considering how hard it is to treat complex PTSD, we're really happy with ketamine and what it did for that.
Yeah. And I know you said that you've done about 1,000, but you've maybe got 300 on your books now.
Yeah.
How long is the average period of time that someone's with you?
The average for our population is about 3-4 years that patients are on.
Any other questions in the room?
Thank you. I've got a couple of questions.
Sure.
One, I think it's just a quick technical one, which is that I saw in your sort of standard blood screen morning cortisol. Is that a specific thing around ketamine, or is that just a exclusive?
No, it's something that is a remnant from my life promotion clinic days, because a life promotion clinic at Griffith University, suicide prevention clinic that I sort of ran for 10 years, we got in the habit of asking for AM cortisol, mainly to see if in suicidal patients there was a relationship between suicidality and cortisol levels. And that's why we kept it when I started, because obviously I started ketamine as part of my suicide prevention work. And then we kept it, even if we didn't really find it useful in terms of suicide prevention, because we sort of knew that sort of a salivary cortisol is more reliable. But funnily enough, we realized that we were picking up on a lot of adrenal illnesses, more than thyroid illnesses, and that's why we kept it, just because it's sort of it's been useful to pick up on all these things that otherwise patients wouldn't have picked up on. and doctors don't usually ask for cortisol that often, and that's why we left it there. But otherwise, yeah.
If I can help.
Yeah.
Given where we are and the audience, can you tell us a bit more about the concerns around substance use? I mean, we've all heard of ketamine as
Yes.
substance abuse, but I mean, where do you draw the line at do you draw the line at gambling, tobacco, alcohol? I mean, alcohol, PTSD.
Yeah.
Prescription.
It's a fine line. Yeah.
Does it stop the ketamine working, or is it simply about minimising the risk of ketamine being misused?
Okay. So the rule of thumb, because it's always a flexible line. Obviously, we exclude people who are abusing opiates in different forms, people who are abusing stimulants different ways, and we are flexible with alcohol abuse, and we are flexible with marijuana abuse, in the sense that we've found that when patients take ketamine, or as they start ketamine, they actually are put off by not alcohol. Alcohol can still continue, but they're put off by marijuana for some reason. So it doesn't give them the same effect, and so it acts as a deterrent. And that's why generally we we allow people who are using pot as a PRN, and because we know that if ketamine works, it won't be as much of a problem later. And in fact, generally, we don't have to deal with patients abusing marijuana when ketamine is stable enough and effective enough. That's why we allow that transition phase where we watch it. But obviously, in essence, even if there's no, the last patient we discharged forcibly, so we unilaterally discharged from ketamine, was somebody who had a history of drug abuse and alcohol abuse, and he had been abstinent, but then he continued to, and he had responded to ketamine, so we were really happy with how he had progressed. Unfortunately, he tended to stop ketamine for a few days and then have 2 or 3 doses at once, and then we would find out that he would ring people in a slurry kind of slurred speech kind of anyway. So we found out these things, and then we gave him a warning, second warning, off. And even if he hadn't, we knew he had not been abusing anything else. But in a way, we want to make sure people don't take ketamine for the other effect of ketamine. And so we have discharged, and in fact, my APRA cases, so all the times I've been involved with APRA around ketamine, has been because I have discharged patients and they didn't like it, and they complained to the ombudsman, and then I had to justify, and they were happy with me discharging. And we've had over the 1,000 patients, we've had to discharge patients like this, possibly 6, which is pretty good. So fortunately, it's testament to the fact that the referrals we accept are generally from another psychiatrist, so they're already screened. So then the clinics are actually not officially available on the internet. And in fact, I'm not on any, so if you Google my name, I'm not supposed to exist anywhere. so that's why. And so we don't do any marketing for the clinics. And that's how we keep the referral base clean from that point of view.
I've got some online questions which I'll run through. One, you talk about a lozenge and then that they hold in the mouth on day one.
Yeah.
And then you also talk about the food content. Is it is it an oral tablet that they swallow, or is it a sublingual tablet or a lozenge? Which is the preferred route that you're trying to look for?
Okay, so initially we thought when we started the research, because before we did it, there wasn't actually any research available for oral ketamine. So initially we thought we had to give it sublingually to get a response, but then within a few months we realized, because ketamine, in fact the main problem is the taste. It tastes horrible, and that's why patients would swallow it straight, and we used the syrup at the beginning, and we very quickly realized that we didn't need any sublingual absorption to get an effect. There wasn't much. In fact, if people keep it in their mouth, they only get more of the anesthetic effect. And that's why, in fact, we encourage people to just swallow it. But it's just that when compounding pharmacists make the lozenges, the instruction is still to hold it, because lozenges are for oral absorption. That's just a sort of
another question is, do you insist the patient be in therapy before prescribing? So if psychotherapy is the treatment, really, so do you insist that they start engaging in that?
No. In fact, by the time people come to us, unfortunately, they're so unwell and they're so exhausted from treatments not working that we, in fact, wait for a few weeks after the ketamine has been doing its job to introduce psychotherapy.
Can you just talk a little bit about the issues with the bladder and ketamine?
Oh, okay. So a very distinctive feature of ketamine is that it disrupts the gel in the bladder that protects the cells from urine. And that's why when ketamine is too much, the membrane of the bladder becomes unprotected from the acidity of the urine. And that's why patients get a chemical burn from the urine. So it's not that the ketamine damages the bladder, it's that it makes it vulnerable to the urine. And that's how we haven't seen it, but the doctors who do infusions deal with it quite regularly. And we know, in fact, I was talking to one just the other day, they've been quite successful in using NAC, N-acetylcysteine, as a prophylactic treatment to prevent cystitis. And the idea is that the closest I've got to it is a patient who had gone up to a high dose, and then she started getting a bit of so the feeling of having to go to the toilet, so it's her irritation, and then we reduced the dose and it settled down, and
Is ketamine prescribing monitored in the same way by MNU as other S8s, the Suboxone?
Yes, right.
Yep.
It is.
It is, thank you. And would a patient who is stable on an opiate treatment program, so on Suboxone or methadone, would they be somebody that would be considered for treatment?
They have been. I know that there's concerns with methadone. Suboxone has been quite easy. So we've had a number of patients on Suboxone, and for different reasons, and we haven't really had any problems. Methadone, we are a bit more cautious, and in fact, personally, I've never treated anybody with methadone, but I know other colleagues of mine have had a couple. But yeah, we sort of we liaise with the methadone doctors and make sure they don't change the dose. And
cool. And I still have more questions. So if others have, please put your hands up. Yes. While I head that way, I'll get you to answer this. You talked about the fact that this has been going on since about 2000. The people have been investigating ketamine for this, but it used to be IV, the infusions. Has your oral had the same efficacy as that? Is it better?
Yeah, well, the main difference is that with infusions, the response, and I've done just a handful of infusions in my career, The infusion is very exciting because you can get patients from suicidal to sort of smiling and joking within half an hour. Unfortunately, the infusion gives a very rapid antidepressant effect, but not much consistency. So it wears off within days. And that's why most doctors who do infusions by now, because of obviously what we've published and what we know now, in fact, they do infusions and then give lozenges or injections for maintenance. And that's what, because the intranasal ketamine is coming to Australia in the next few...
Well, that's another question.
So it's happening. So they're expecting TGA approval within first half of the year, and that's what hopefully we'll be able to do, is to do rapid antidepressant effect, because the lozenges can take up to 4 or 5 weeks to kick in, but then they are very stable in their effect. That's the trade-off.
Any other questions in the room? Yes.
Hi, just following on from what you were saying about the idea of Suboxone and methadone being different in terms of it, and that kind of leads on to a second question. Is that you're just worried about the sedation effect and methadone, or is that an NMDA?
No, in fact, it's more
other NMDA drugs or glutamate drugs like pregabalin. I'm just trying to think of
Well, I guess it's sort of because ketamine potentiates other chemicals, we found Suboxone, people can stay on the same dose, it's pretty stable, there's no changes to tolerance and sensitivity. But with methadone, we expect the sensitivity to change. And that's why the idea is that there's a higher risk of respiratory depression from methadone. We haven't had it. It's just that the doctors who were giving methadone sort of freaked out about having ketamine in the mix, which is obviously justified. So that's why we've been more cautious. And it's one of the things that obviously you want to be aware of. But we haven't had any complications.
I'm just thinking of other NMDA drugs as well. So
well, sort of
or glutamate drugs. Probably more accurate. So things like the gabapentinoids.
That's right.
And so forth.
Yeah.
Barbiturates, I presume, well out. But is that an issue at the moment? Because we're seeing a lot
Not
of
really.
So.
Yeah.
Okay.
Yeah, I guess it's a side issue that in fact I am thinking of researching. So what we have noticed consistently is that if a patient is on Targen and we give ketamine, they can't tolerate more than 20 milligrams a day of Targen. And then for some reason they become oversedated, they get side effects from Targen beyond what you would expect.
Is that a similar effect to the pregabalin effect on opioid tolerance, because it only affects a subset of opioids?
Well, I guess
is that a second messenger issue?
Possibly, but it's one of those things that it's been cropping up because obviously we see a lot of chronic pain patients.
Yeah.
In fact, many of the referrals have come from pain specialists, and that's why when you sort of keep seeing the same clinical picture where patients say, I used to be able to take 60 milligrams of Targen, now if I get 15, 20, I'm knocked out. And then, in fact, I've gone back and looked at some of the files. I've got these patients who have been on 10 milligrams of Targen for 2 years, and I don't hear them say, can I have more or can I change the dose? Which is, obviously we know in pain medicine is the main reason why they give ketamine, to reduce tolerance to opiates, but it's never been described oral ketamine or continuous use of ketamine to keep the dose of opiates lower. Because that's something that if I had enough time, I would look into, because it would be really useful to know.
Well, if it's the same mechanism as the pregabalin interference with opioid tolerance, then you ought to see a differential effect. So you should have one group with oxycodone, morphine, diamorph, and a separate group that doesn't have that effect.
That's right.
And so you.
Well, but in fact, I've had, in fact, it's the same. So I can talk about one patient in particular. He was on ketamine and Norspan, and he could never get enough Norspan in the system. When I switched to Targen, he couldn't take more than 10, and he never complained about needing or wanting more, and he had been complaining every session when he was on Norspan. And that's something to look into, because he's, so in terms of the effect and the side effects profile.
That's fascinating. That's a whole new world of research right there. Listen, I'd like everyone just to thank Dr. Angelo De Gioannis.
Thank you.
Thank you.